as a pediatric otolaryngologist, I think that frequently we're the first line of seeing patients that have syndromes. Many times we're in a position, because we're examining the head and neck in detail day in and day out in children, we're able to take in nuances that sometimes the pediatrician may overlook. One of the things that I always say to our residents, or when I'm giving lectures on these topics, is that the first thing you should do is look at the patient when they walk in. Look at their facial features. You want to take a total assessment of the patient. As part of the whole head and neck assessment, looking at the upper airway, these patients frequently also have problems with either adenoid hypertrophy or tonsil and adenoid issues. In patients with Hunters, they may come in for middle ear fluid, but they start to develop coarse facial features, and they get some of that frontal bossing, wide set eyes, a flattened nasal bridge, low set ears. They all have airway issues. Many of them will need their tonsils and adenoids out. Obstructive sleep apnea symptoms, the snoring and the restless sleep and the classic OSA symptoms. But sometimes you won't make the diagnosis the first time you see them. You see them, they come back, and now their facial features have become a little more pronounced. You won't make the diagnosis frequently in a child who's 1 because they won't have had the classic facial features of Hunters. But when you see them back when they're 3 or 4, those facial features have now they've kind of crystallized a little bit into something a little more classic for the appearance of Hunters. This is a hard thing to teach, but the reality is that those patients have a look, they have a certain facial appearance. The facial features for Hunters is what really grabs me. And I actually think it's pretty distinctive if you know what to look for. I don't know that it's important for me to have the confidence that I know what the diagnosis is. I think it's important for me to know that I have enough of a clinical suspicion that you may have a syndrome and that you need to be evaluated by someone who does that, and in this case, a geneticist. I'm not a geneticist, but like I said, I look at enough children to know when I think I have a good handle on identifying a syndromic child when I see one. The internal dialogue is probably there are a couple things in terms of whether I really think the patient has a syndrome and what kind of checklist I need to go through, and then how comfortable am I and what's my relationship with the patient that I can have that dialogue, or do I need to then try to address that with someone who has a better medical relationship with that family. In other words, how comfortable am I going to be to bring up the subject of the fact that your child might have a syndrome? Because for a lot of patients, that's a very difficult thing to get your head around. It's also difficult if I'm meeting a patient for the first time and I say, oh, I think you might have a syndrome. You need to go see a geneticist. That's a potentially very threatening thing for a parent, but it doesn't mean that it should get ignored. If I don't have that relationship, I may not have the conversation with the family right away, but I may call the pediatrician or whoever it is who sent me the patient to have that dialogue with them if I have a concern. And of course, the other dialogue is, well, what is it that's going on here that makes me think that this kid is syndromic? Is he having developmental problems associated with some other clinical findings that suggest some type of syndrome? As a result, we'll then point my history and physical in that direction. I might look for, if I see a patient who comes in and I'm concerned that they have Sprintson syndrome or velocardiofacial syndrome, I will specifically ask them about developmental issues and cardiac problems and whether the child's having speech issues. I might pick up the phone and call either my partner or another pediatric otolaryngologist who I respect, who I think has probably had experience with this, and send them an email and say, you know, what do you do with these guys? What do you do with these kids? What's your experience? So I think the contact with other professionals who treat syndromic children, they have usually a wealth of knowledge and comfort and know the ins and outs of taking care of those patients. And I think that is something that is hard to get out of a textbook or online or anywhere else. It's understanding from someone who really has the experience of taking care of patients like that, what to do with those patients. You know, in terms of support, I think that the biggest issue is probably education. You know, I mean, people need to be educated that they are probably encountering syndromic children all the time. And like most diseases, awareness of the existence and the prevalence to which we see Hunters or any syndromic child for that matter. You see more syndromic children than you realize, almost invariably. I'm sure there are syndromic children who walk out of my door who I miss. I like to think I don't, but I'm sure that there are syndromic children that we all don't identify. And so the only way to try to not miss them is to constantly think, could this child be syndromic? It is important to be on the lookout for these patients because they walk in our office every day. It's just a matter of us being aware of them.